Everyone, and good afternoon again to our ECHO family, and welcome again to our MRF HIV STI ECHO series. This is our 52nd session. Our family is growing all the time, and we welcome all our old family and some of our new family, especially Luke. Thanks so much for coming. We very much appreciate your time and your presence and your wisdom that we hope we'll be able to borrow from this afternoon, especially when it comes to our case. So again, with me in the hub, to my right is Dr. Musa, to my left is Dr. Edwards. And he's going to be given the didactic today. And the didactic today is an old and new topic, syphilis in pregnancy. And Dr. Edwards, I'm sure, will go in great detail, but the only worrying things we know is that syphilis rates around the world are still an issue. And we are in the middle of this eradication program for maternal transmission of HIV and syphilis. So this is a part of the EMTCT that deals with syphilis and syphilis transmission in pregnancy. So I'll get the presentation up, and Dr. Edwards, I'll have it as soon as we're doing. So just confirming everyone can see the slide.
Yes, we can.
Yes.
Okay, afternoon everybody, and welcome. Today we're going to chat a little bit about syphilis and pregnancy. I don't want it to be too long because syphilis is really complicated, so I'll try to simplify it as much as possible for you. Next slide. So just a brief overview of syphilis. Is a systemic human disease. It's caused by an organism called Treponema pallidum, and we say T. pallidum. Is usually acquired by sexual contact or blood transfusion. So we screen all our bloods for syphilis. And we have early syphilis, which is primary syphilis, secondary syphilis, or early latent. And I'll just briefly talk about those. And then we have late syphilis, which is latent syphilis, late latent syphilis. And we have tertiary syphilis, cardiovascular syphilis, and neurosyphilis. And then syphilis can also be transmitted from mother to child. And this is our lecture today. And this may be early, which is in the first 2 years, or late, where you might get stigmata of congenital syphilis. And I'll show you some brief pictures of those. All right, next one. So in terms of stages of syphilis, just to show you there, the primary stage, the person usually develops a painless ulcer, usually on the anogenital region, so the genitals or the anal region. But I've seen primary syphilis on the finger, on the breast, on the tongue, so that it could occur anywhere. All right, it's a painless ulcer. It's called a chancre. It starts about 21 days, following infection. And it lasts 2 to 6 weeks. Because it's painless, some people leave it and then it just heals on its own. All right, but the syphilis don't go away. After that, you could get secondary syphilis, which is characterized by a rash. The rash is usually generalized. Is non-itchy. It may involve the palms and soles. So I showed you a picture there of the palms and soles. It may involve mucocutaneous lesions, for example, you get mucus patches in the mouth, you could get wart-like lesions in the genital area, condylomata lata, all right? It may present with fever and muscle pain, and it could affect any part of the body. Secondary syphilis on whole is called a great imitator. Secondary syphilis usually starts 2 to 3 months after the onset of the chancre, that's the ulcer, and lasts about 2 to 6 weeks. Next one. Then we talk about latent syphilis. Latent syphilis means somebody goes in for blood tests, and the blood test comes back positive for syphilis, and the patient has no signs and symptoms. If the patient had a negative syphilis test within the last year, we call that early latent syphilis. If the patient can't recall when they had a syphilis test or they never had a syphilis test, then the patient who just has a positive syphilis test and with no symptoms, and we don't know when, this is called late latent syphilis or syphilis of unknown duration. And then we have the tertiary stage of syphilis. This usually takes 15 to 20 years afterwards. People may develop involvement of the central nervous system called neurosyphilis. It may affect the cardiovascular system. You get cardiovascular syphilis, or you may just get some skin conditions, and this is called late benign syphilis. All right, and as I said, this occurs usually, 15 to 20 years after infection. Next one. So let's talk about syphilis in pregnancy. So the manifestations of syphilis in pregnancy are the same for a non-pregnant woman, and syphilis may be acquired at any stage of pregnancy. So early pregnancy, late pregnancy, all right? If a pregnant woman is infected, the organism Treponema pallidum enters the bloodstream and then goes across the placenta to be transmitted to the fetus. Transmission usually occurs, around the second trimester, 16 to 28 weeks, but it can happen as early as 9 weeks, or it could even happen in the third trimester. So the likelihood of transmission of syphilis to the fetus depends on the stage in the infected woman. So if the woman has primary or secondary syphilis, the concentration of the organism is highest in these conditions, and the risk of transmission is greater. For things like latent syphilis and stuff, the concentration of the organisms is less. So, I mean, the risk of transmission is decreased, but there's still a risk of transmission. Next one. So mother-to-child transmission of syphilis, called congenital syphilis, is usually a devastating illness to the fetus. So if the maternal infection is not detected and treated sufficiently early in pregnancy, it's bad news for the fetus. So approximately half, 50%, and I'm going to mention it again, approximately half, 50% of infected pregnant women will experience adverse outcomes due to syphilis. So again, let me say it again. And this is why we want to eliminate mother-to-child transmission of syphilis. Approximately 50% of infected pregnant women will experience adverse outcomes due to syphilis. And the burden of morbidity and mortality due to congenital syphilis is high. So they looked at the year 2020, that's the World Health Organization, and they estimated in 2012, there were 350,000 adverse outcomes, pregnancy outcomes worldwide, which is attributed to syphilis. And these included 143,000 fetal deaths or stillbirth, so death of the baby. 62,000 neonatal deaths. Neonates means a baby within the first 28 days of life. So the baby is born, and within the first 28 days is called a neonate. So you have 62,000. So here we're looking at over 200,000 deaths of babies. Then you have 44,000 babies being born with preterm or low birth weight. And then you had 102,000 infected infants with syphilis. They were alive and they were infected with syphilis. Next one. So you can see the issue there. So in 2013, they looked at 6 case control studies. They did a systematic review comparing the outcomes from untreated maternal syphilis, and they looked at the difference between women with untreated syphilis and those without syphilis. All right, so they found that women with untreated syphilis, 21% of them will have a stillbirth or fetal loss, so the baby will die, 21%. Neonatal death, there's a death within the first 28 days, 9% of the babies will die within the first 28 days. So 30% of the children will die from untreated syphilis. Prematurity or low birth weight, 55%. And then evidence of syphilis in the newborn, so a child being born infected with syphilis, 15%. So if you look at it, this adds up to about 50%. So untreated syphilis has adverse outcomes in about 50%. And as I said, about 30% of the babies will die. Next one. So they looked at congenital syphilis in the US, all right? Between 2008 and 2017, the greenish or aquamarine bars there, that is the congenital syphilis by year of birth. So each year of birth. And you can see the black line going across there. That is primary and secondary syphilis in women, all right? So in the US, congenital syphilis rates increased by 85.9% between 2012 and 2016. So you can see the rates going up. And in the US, again, the congenital syphilis, all right, rate increased 153.3% between 2013 and 2017. And this mimics the increase in primary and secondary syphilis, that black line going across there. You see in women between the ages of 15 to 44. So what we're saying basically in the US, there's an increased prevalence of primary and secondary syphilis among pregnant women. And this is reflected in increased congenital syphilis trends. We actually did a study probably about 2 years ago, looking at syphilis in men who have sex with men, and we found that 43% of the men who have sex with men attending the Mrftt clinic were positive for syphilis. All right, they had syphilis that we had to treat. We also just completed a recent study where we're looking for risk factors again, so we have to analyze this. We found that 28% of the men, and this was done last year, 28% of the men who have sex with men, again, were positive for syphilis. So syphilis is very high in men who have sex with men right now in Trinidad and Tobago. Next one. So continuing with the syphilis in pregnancy, most untreated primary and secondary syphilis infections in pregnancy result in severe adverse outcomes. And I showed you that, and I'm going to show you some pictures also. Latent syphilis infections in pregnancy also cause serious adverse pregnancy outcomes in more than half the cases, but most of the outcomes, adverse outcomes, occurs when the woman has primary or secondary syphilis. Syphilis in pregnancy can be easily cured by penicillin, all right? So if you treat the woman, you screen her in pregnancy, treat her, all right, the risk of adverse outcomes to the fetus is minimal if the mother receives adequate treatment during early pregnancy. Ideally, we like to do before the 3rd trimester. Next one. So how do we screen for syphilis in pregnancy? We basically screen for syphilis in pregnancy, same way we screen for syphilis in a non-pregnant person. We screen them with a VDRL, which is a non-treponemal test, which is a venereal disease research laboratory test. All right, and then once that, if that comes back positive, we have to confirm this test with a treponemal test. And the one we use in Trinidad is a treponema pallidum particle agglutination. Why do we have to confirm? Because women could have a false positive VDRL just by pregnancy itself alone. If a woman had a vaccination, she could have a false positive VDRL. Somebody who has a connective tissue disorder like lupus could also have. So there's a list long like this where you can get false positive VDRLs, all right, from various conditions. So anytime you get a positive VDRL, you need to confirm it to make sure this is actually syphilis. And the treponema pallidum, the treponemal test we use in Trinidad is a treponema pallidum particle agglutination. All right, next one. So this is the algorithm here. So women come in, or anybody comes in for a screen, we do a VDRL at them. If the VDRL is non-reactive, we say, good, you don't have syphilis. If the VDRL is reactive, then we need to confirm the syphilis, and we do the treponemal test, which is the TPPA, the treponema pallidum particle agglutination. If this is non-reactive, we tell the person you don't have syphilis. If this is reactive, then we say the person has syphilis. The only thing is we can't distinguish between treated syphilis or untreated syphilis, and I'll talk about that. Next one. So in terms of syphilis in pregnancy, this is gestational syphilis. This is diagnosed by routine serological screening of all women during early pregnancy. So we like women to come in early in the pregnancy so we can screen them for syphilis. And if the syphilis test is positive, then we need to treat them. The problem with our syphilis testing is that all the health centers throughout Trinidad and Tobago send their bloods to QPCC. The QPCC lab was actually now moved to public health lab to do the syphilis testing. The problem is getting back the results to these patients, so the treatment could be, offered in a timely manner. And I think that's where we kind of drop in the ball. So what we're hoping to propose is that we could probably offer rapid syphilis testing to those pregnant women where you can actually diagnose them and there and then, all right? You can send off the bloods once they're positive to QPCC and DPHL for confirmation that you could start treatment, all right? So there's a proposal. We suppose the rapid syphilis test was validated throughout the Caribbean. So we're working in Ministry of Health to see if they could try and offer rapid syphilis testing to the pregnant woman, all right? So serologic testing, if a woman is high risk, so we like to screen the woman when they come in. So hopefully they come in the first trimester, usually before 12 weeks of pregnancy. And being woman is high risk, we tend to repeat the syphilis testing like the HIV testing in the 3rd trimester. So woman comes in to antenatal clinic. That's a clinic where the pregnant women go. We do a number of bloods in them, including HIV and syphilis. And we tend to repeat it again in the 3rd trimester, you know, after 28 weeks of pregnancy. Any woman who has a fetal death after 20 weeks of pregnancy should be screened for syphilis, because I told you syphilis causes about 30% of fetal deaths. And women who do not receive prenatal care, meaning that women who do not come to clinic, all right? And some of them just come to the hospital to deliver, all right? We need to screen them at that time and make sure that they're both, the mother and the infant, are screened before they're discharged to make sure that they don't have syphilis. Next one. In terms of treatment for syphilis, it's the same treatment we use for anybody who has syphilis. The problem is we're having a problem with penicillin. Now, penicillin is so cheap that the pharmaceutical companies bring it and don't make any money. I think a dose of penicillin is probably less than $1 US. So the pharmaceutical companies who bring it in, they're making no money, so it don't make sense they're bringing in penicillin. So we short of penicillin generally worldwide, at least, especially in the Caribbean. So in Trinidad and Tobago, the government buys penicillin for pregnant women alone. All right. So we usually treat them with penicillin, and penicillin is the only drug that crosses the placenta and goes across to the fetus. So what we use in non-pregnant women, because we can't get penicillin, we treat with doxycycline, which is tetracycline, but this is no good for pregnant women because it has a bad effect on teeth and bone development in the fetus. So tetracyclines are contraindicated in pregnancy. Sometimes you also use another drug called erythromycin to treat the syphilis, but this doesn't cross the placenta and doesn't treat the baby. So what treats the baby is the penicillin. Next one. And we usually give benzathine penicillin G, all right? 2.4 mega units as an injection. We give it you can get it in the buttocks, all right? And we treat primary, secondary, early latent syphilis. It's generally good practice we normally treat with 1 dose of penicillin, but because of pregnancy and stuff, a lot of experts tend to recommend that, you know, instead of giving 1 dose alone, let them come back in another week and give them 2 doses, you know, just to make sure that the baby is treated. All right. So it's good practice to treat the woman, all right, 7 days after the first dose, all right, just to make sure the baby is treated. But just to let you know, the treatment for primary, secondary, and early latent syphilis is 1 shot of penicillin. We give 2 shots in pregnancy just to make sure we treat the baby. For treatment of latent syphilis or syphilis of unknown duration, what we do is we ask the woman to come in once a week for 3 weeks. So she come in once a week for 3 weeks with 3 injections of penicillin, all right, to treat the baby. Next one. Now, some people have allergy to penicillin. And as I say, this is the only thing that treats the baby. So what we do is desensitize them. So they have, you know, like if babies are sick, they have little penicillin syrup that they take. So what they do, how they desensitize women is they usually admit them to hospital, all right, and give them a little bit of the liquid penicillin and increase the dose slightly. Now, they've had 1 or 2 people who had a severe allergic reaction when they had to intubate them. So that's why you have to be in hospital to do this. But a lot of patients, you could gradually increase the dose of penicillin, desensitize them, and then you could treat them with penicillin, all right? So this is what the desensitization is. You give them increasing doses of penicillin slowly, you know, over the course of a day and monitor them for allergic reaction, all right? Now, some persons have neurosyphilis, meaning syphilis affecting the central nervous system. Again, you have to admit them to hospital and then give them IV penicillin, all right, for 10 to 14 days. Again, with patients with HIV, we usually treat the same way in terms of regular people, but I mean, sometimes with HIV, the titers, when you're following the patients, they don't go down quickly, so sometimes you have to consider neurosyphilis, and I'll talk about that. Next one. So in terms of treatment of syphilis in pregnancy, so following adequate therapy for primary or secondary syphilis, all right? We usually try to follow up the patients, but because pregnancy is 9 months, it depends on when they come in, you know, we tend to follow them 8 weeks after, but the titers usually start decreasing at least fourfold, 3 to 4 months after, all right? So usually when we do a syphilis test, the VDRL usually comes up, so it usually comes back, say 1 in 64, all right? If you treat the patient, you look for a fourfold drop in titer, all right? So you hope it goes down to at least 1 in 16, 3 to 4 months after treatment, or it goes down to negative. If treatment occurs in the latent or late stages of pregnancy, all right, what we find is a more gradual decline in the VDRL titers, and then some people may actually have a 1 in 2 titer or 1 in 4 titer, which may persist for years, all right? And we call this a serofast too. But how we could distinguish this from somebody with syphilis, we asked if they ever had treatment for syphilis, all right? In some women, the titers fail to decline. And if the titers fail to decline, this would either mean they have reinfection or they may have neurosyphilis, so you need to investigate them further. Next one. So basically, a confirmed serologic test for syphilis, all right, in the presence of treponema antibodies, all right, cannot distinguish between past and current infection. So if we screen here, your VDRL positive and the TPPA positive, we have to decide if you were you treated in the past, all right? Because remember the titers drop over time, or is this a new infection? And you usually get this from the history. So you ask a person, did you ever get treatment for syphilis? And they say no, then we go ahead and treat them, all right? So a case of treated syphilis is defined as a reactive VDRL and TPPA following a diagnosis of syphilis. And then after treatment, you get a fourfold drop in the titers, or the VDRL becomes negative, all right, following treatment. So that's a case of treated syphilis. Next one. Now, some people may have syphilis. Remember I tell you we have syphilis in men who have sex with men, and they get another episode of syphilis again. So a repeat episode of syphilis is defined as a reactive VDRL and TPPA following a diagnosis of syphilis, all right? Then you treat them, you get a fourfold reduction in the VDRL titers, or the VDRL becomes negative, all right? So you treat them, the VDRL becomes negative. And then 6 months later, repeat the VDRL and you see it going back up again, all right? And if there's a fourfold increase in titer with a titer of at least 8 bills, then we consider this as a repeat episode of syphilis, all right? So people could get syphilis more than once, that's the point. But we could cure syphilis, but if you go and expose yourself again. So once we identify a woman with syphilis, we ask her to bring in her partner, all her partners to treat them so that she may not be reinfected again. So that's contact tracing. Next one. All right, and just following up again, we usually try to follow up positive VDRLs about 8 weeks after treatment. But remember, I told you sometimes it takes a long time to drop it. So, I mean, sometimes it may not actually you may not actually achieve this fourfold decrease in titer because the period is too short, but that doesn't mean the woman isn't treated. Next one. So in terms of children, all babies, if even they have no symptoms, if they are born to a woman who is positive for syphilis at birth, they should be given an injection of penicillin as soon as they're born, okay? And diagnosis, and then the baby should be investigated to make sure that they don't have congenital syphilis, and the pediatricians do that. Next one. Newborn infants now who show any signs of congenital syphilis, they should be treated again with penicillin for about 10 days. Again, the pediatricians deal with that, all right? And they require hospitalization and treatment. So the children with syphilis that is transmitted from the mother require hospitalization and treatment with penicillin. Next one. So in terms of congenital syphilis, just briefly, all right? This has become a rare disease in developed countries, but you can see what's happening in the US now because there's increased primary and secondary syphilis in women. This is going back up again. So babies may suffer severe sequelae. Besides the deaths I mentioned, they may get cerebral palsy, They may get hydrocephalus, which is fluid around the brain. They may get hearing loss, or they may get deformities of the limbs, all right? And all of these can be prevented if you treat the mother during pregnancy. Next one. So just to show you some of the late manifestations of syphilis after 2 years, you may get eye damage, you may get deafness, it may affect the joints, it will affect the teeth, all right? You get fluid around the brain, you can get mental retardation, you can get a saddle nose, you get a high arch palate, all right? You can get fissures around the mouth, you could get saber shins, and then I'll show you, go ahead. So just to show you a couple of pictures of the babies. So remember I told you 30% of the babies die, but then some of them may develop things like snuffles, mucus patches, you know, or damage to the palate, or they may get a skin rash where they get these lesions on the soles, or the baby might have a high arch palate. You can see up in the mouth how it's high. Next one. Then you can get, it affects the teeth. So you can get Hutchinson's teeth. You see these peg-shaped teeth in the children. Or you can get a saddle nose. You see the nose there. Or you can get frontal bossing, meaning the forehead is bigger than normal. All right, next one. Or you can get saber shins, where you get bowing of the shins, or you can get skin lesions. All right, so just to show you that syphilis in pregnancy is a really severe illness. All right. 30% of the children untreated, the mothers, if the mothers untreated, they die, all right? And you get 50% adverse outcomes. And I just show you some of the adverse outcomes of syphilis. Okay, so thank you.
Thank you, Dr. Edwards, for that excellent presentation, as usual. I will just open the floor for anyone if they had any comments or questions that you wanted to direct to Dr. Edwards while he's here with us. I'd also like to, again, I don't mean to pick on the QPCCT, but I'd be really interested in how many cases they've actually seen, because I've never seen a case of congenital syphilis. One of our mothers, since I've been here, was diagnosed with syphilis in pregnancy, and she had to get treatment, and the baby had to get treatment, like, I think she had,
Right.
had a couple of meningitis, actually.
Right.
But the baby turned out okay, and she's doing well now. That's the only case I can remember. So we're really interested to see how common it really is, where pregnant women are bringing further QPCC for management. While the questions are coming in, just so I sort of raise this issue with respect to the whole elimination aspect of child transmission of HIV and syphilis. And just, you know, in my own experience, I'm still realizing, you know, in terms of following up with pregnant mothers who are VIDRA positive in pregnancy, how much success, how, in terms of partner notification, partner testing, and partner treatment. Do you have any sort of, I mean, do you come across anything, or do you have any information from QPCC about?
I'll probably let the QPCC doctors. I see Dr. Lecter and Dr. Charles there. Who again there? Any one of them want to tackle that? Dr. Charles, Dr. Letron. So we're asking about syphilis in pregnancy in terms of follow-up and follow-up of partners and things. How effective is that done at QPCC? You have to turn on your mic, unmute yourself to speak. From what I know in terms of syphilis in pregnancy, so as I said, go ahead, somebody's talking. Go ahead, Dr. Charles.
Yeah, it's just that I'm driving. That's why it took so long, but I pulled aside. We do the best that we can in terms of getting the partners in, treating, but I really can't give you any data as to how effective it is, but we always ensure that we treat mother and partner. In terms of what Dr. Boyce was asking about congenital syphilis, we would not see those cases, so we wouldn't be able to give you any information on that. I don't know if Dr. Letron, you've been there a little longer. I don't know if you could add anything, please.
I think we're working pediatrics.
So, currently, right now, in terms of the congenital syphilis cases, from what I have seen, we aren't having that much. I think maybe we had probably 2 positives or 1 positive within the past year. And as Dr. Charles said, we don't normally see them. It's more based in NICU, Port of Spain if it's Port of Spain, or if it's Mount Hope, peds will see them. So we don't really interact with the babies that much.
And in terms of positive women, the mothers who are positive, how many we would see a year? You know, women who are positive for syphilis. I mean, I don't think it's that much, but it's probably good to do a study. How many you all would see, roughly, women who positive with syphilis?
I can't answer that one off the top of my head, but I would think we see quite a bit, you know.
Pregnant women, huh? Pregnant women.
Pregnant, oh, okay. Yeah, pregnant women may not be that much. Let's say in 1 year, if we see maybe 10, but that might be, we could say that's a good average to go with, if so much. But yeah, pregnant women is not so much. One of the problems though with the pregnant women is that sometimes when they do the testing, so in those, like, if they do it in those communities that's far off and the results take long to get back to the community, it's kind of difficult to get the results back in time over there. And then sometimes you have a lot of patients who move. So you might have somebody who this week they're living in Port of Spain and they went Port of Spain to do their VDRLs and everything. And then next 2-3 weeks when you're looking for them, they move to Granby or you don't know where they have moved to and they lost the follow-up basically.
So that's why we want to introduce rapid testing at the health center so that, you know, you do the rapid test, if the rapid test is positive, and you can start treatment, but you send the bloods for confirmation to TPA, just like what we do with HIV, you know? So that's what we hope to introduce, you know, soon. We talk to the ministry about that.
Okay, thank you so much, everyone, and thanks for all the participation, all the input.